Hello everyone, welcome to our webinar. The Ellen Satter Institute, in conjunction with the Santa Clara County Department of Public Health, are happy you've joined us for this webinar. It's a countywide obesity prevention strategy, speaking with one voice. I'm Katie Benzie, the Executive Director of the Ellen Satter Institute. The Ellen Satter Institute is a not-for-profit organization that was formed in 2008. The Institute devotes itself to passing on the legacy of the Ellen Satter's feeding dynamic and eating competence models through education, training, and research. If you find today's webinar helpful and you would like to support more programming like this, please support us by making a donation. You can find the Donate tab on ellensatterinstitute.org. Or if you're interested in being a part of us, we'd love to talk to you more about that, so please email us. As far as our speakers today, I have the honor of working with both of these amazing women. They're highly experienced practitioners of the feeding dynamics model who have volunteered their time to bring you this much-needed seminar. Our first public speaker is Carol Danaher. She is a faculty member of the Ellen Satter Institute and the public health nutritionist in Santa Clara County, California. Our second speaker is none other than Ellen Satter herself. She is an internationally recognized eating and feeding authority, and many of you are here because I know you know her work. So thank you so much, Carol and Ellen, for being here and taking your time. A couple of last notes. There will be some time at the end for questions, so feel free to type them as they come to you. You can just type them in. We're also offering a certificate of participation. It'll be available on ellensatterinstitute.org. And last, we ask you to please take a moment and fill out the evaluation that we're going to email you after the webinar. Your feedback is so valuable to us as we plan more of these high-quality webinars, and it also helps us seek grant funds to support the webinars. So I think that is it for me. And Carol, I am going to turn this over to you here.
Okay, great. Okay, and my screen should be up for all to see. Okay, thank you, Katie. And we're going to talk about my work within the Public Health Department and the work of many others in Santa Clara County, California, to make Ellen Satter's Division of Responsibility the norm for child feeding guidance. This is our introduction and our agenda, and I hope that by the end of our time together, you will understand how what you've learned can be adapted and implemented in any county or entity serving families with young children. Let me just put us on the map. This is Santa Clara County, is central in California, very near the Pacific Ocean. Santa Clara County is very diverse in terms of ethnicity, race, and income. It was formerly an agricultural area known as the Valley of Heart's Delight, and now, of course, we are in the heart of Silicon Valley, and we're home to Google, Hewlett-Packard, Facebook, and Apple. Our rates of low-income children over the 80th and 95th percentiles BMI for age are not the highest in California, but depending on age and ethnicity, they are 1.5 to 6 times the rates expected in a normally growing population of children. The focus today is on early intervention to support healthy feeding practices between caregiver and child. Now, the rationale for early intervention is powerful. Healthy feeding practices support a child physically and emotionally and have lifelong impact. I think that most of you are familiar with child feeding practices and Satter's Division of Responsibility. However, given our diverse audience today, I will briefly describe this parenting model upon which the child feeding collaborative intervention is based. Division of Responsibility is a developmental stage-based parenting model. It defines the feeding relationship between parent and child. The model provides parents and those advising parents with a concrete strategy for developing a positive feeding relationship and for finding solutions for feeding concerns. Here you see the 5 domains of the Division of Responsibility. Combined, they teach an authoritative style of parenting in which parents provide the structure or rules for the eating environment, and these are the what, when, and where that you see, and children have autonomy over how to behave within that structure. in which they decide how much and whether or not to eat from what the parent provides. Division of responsibility is often referred to as the trust model, as parents must trust the child to eat the amount that is right for them within the structured feeding environment. In this presentation, I will refer to these 5 domains as the 5 keys, and I also want to now turn this over to Ellen.
Actually, just a second. I'm getting some people, they can't hear you very well, so if you guys can just speak up a little bit, they're requesting, please.
All right.
Thank you.
I'm as loud as I can be on my computer. This is Ellen speaking. Hi, everybody, and thank you so much for tuning in today. Carol and I and Katie have been just working like everything on this presentation, so hope it's useful to you. It was around the division of responsibility that I first met Carol when I was in San Jose over the many years, I guess since 1983 when Child of Mine first came out, presenting workshops for California Dietetic Association, WIC, and other agencies. When Carol started working on this project, she wrote consulting time with me into it, and I'll be chiming in as she presents this material. Carol?
Okay, thanks. Now I've turned up my volume to max, and so Katie, interrupt me if you know, we can't, the audience can't hear me very well. All right, so I want to now describe the Childhood Feeding Collaborative. Childhood Feeding Collaborative is a project within the Public Health Department, and its stated goal is what you see here, to improve parenting skills around feeding at the earliest opportunity to reduce known risk factors. Now, this is a carefully crafted goal. Although you'll learn later what our behind-the-scenes goal is, we frame this goal around obesity prevention because in 2007, when I was writing the first grant, child obesity was where the money and interest lay. Now, Santa Clara County has excellent programs that support and promote breastfeeding, so we continue the support for best feeding practices by starting with a transition from a milk-based diet to solid foods. That's our starting point. Behavior change is facilitated when adults hear a consistent message from a variety of sources and formats. Childhood Feeding Collaborative strategy is based on this principle by coordinating communication on child feeding among relevant service providers. The collaborative targets are the key service providers in 3 different sectors. The first of these is healthcare. Parents and child will visit the pediatrician 14 times in the first 5 years of life. Feeding guidance is the theme for most of those visits. I work with pediatric clinic administrators to build policy support for feeding education based on division of responsibility. Families often see a different pediatrician visit to visit, so this coordination of communication within clinics benefits families. The intervention with the pediatric healthcare provider is to train them on how to give division of responsibility-based feeding guidance during that well-child visit, how to refer families to our parenting class, that's that 5 Ps class you see there, and how to refer to our obesity treatment program, the Pediatric Healthy Lifestyle Center. Next, how the pregnant woman eats will influence how she feeds her child. We are hoping to begin this year to partner with obstetric providers. We've done work with prenatal class providers so that we can promote eating routines before the baby is born. Santa Clara County has 2 managed care plans that serve low-income individuals. We reach large networks of pediatricians and parents through these health plans. We've got a very collaborative relationship with these plans who provide the collaborative with funding and in-kind support. The health plans offer our Division of Responsibility-based 5 Keys class to their members and sponsor physician trainings, at which I present. And this is a mutually beneficial relationship because Childhood Feeding Collaborative programming meets the health plan's need for obesity prevention programming. Pediatric Healthy Lifestyle Center, that's our obesity treatment program, and its nutrition guidance for children who are overweight is based on the division of responsibility. I work closely with their dietitians and pediatricians. Pediatric Healthy Lifestyle Center also refers all of its clients to the 5 Keys class. So I want you to begin to visualize with this slide and the next two how a low-income family has multiple opportunities to receive division of responsibility messages, beginning with that routine visit to the pediatrician, who then may refer the family to the 5 Keys class, and then, if needed, to the Pediatric Healthy Lifestyle Center. The next sector that I'll talk about is public health programs. Each of these public health programs provide nutrition and health services to high-risk families, and they serve the same clientele as our county and community-based pediatrician. Childhood Feeding Collaborative works through organizations, administrators to gain buy-in for the intervention. Each of our partnering organizations then identifies a key staff person or persons who we train, and they serve as that organization's child feeding expert. These feeding experts then train and support other staff members. In the case of WIC, we train all nutrition staff. About 60% of infants born in Santa Clara County will enter the WIC program sometime during the first year of life. So this is a very important partner. Each of these organizations also refer families to the 5 Keys class, and in the case of WIC, we have worked with them to redesign the class so it fits within their group classes. We contracted with Ellen Satter Associates to provide the trainings for these experts. It was either a 3- or 4-day training was provided. The third and last sector we target are community-based programs. Our partners in this sector include community-based organizations that provide parenting classes, health and wellness programs, child care, and after-school programs, and so on. We extend our model to community organizations in that we, again, gain support at the top and then provide training to key staff members to build capacity within the organization for this consistent division of responsibility-based feeding guidance. The families served by these organizations are also served by our public health and healthcare providers. And I hope by now you can really see how with all of the different service providers that a low-income family may have a relationship with, that they have the opportunity to hear a repeated and consistent division of responsibility-based message. The 5 Keys class, let me just spend a little bit of time telling you about this because this is really key to our success in working with these multiple service providers. Healthcare and public health providers, community providers, they are time-stressed and have competing priorities. They do not have time to go into the detail that parents need around feeding practices. So having a free referral resource is extremely valuable to them. There is no threshold for entry into the class. It's free. It's offered throughout the county in 3 languages, and it's learner-centered. And this class is supported by either offered or supported by our health plans. Ellen, is there anything you would like to add?
Yes, I definitely would. You know, I have a comment and a question. Carol, these are all agencies and care providers that self-identified and contracted with me and with ESI for training and feeding dynamics over the years. However, until you targeted them for this collaborative effort, it seemed that collectively they just couldn't get much traction in applying the division of responsibility. Each agency would express frustration about conflicting messages from the others. You address that communication problem by working with them all. How did you identify the agencies and other participants for targeting and inclusion in CFC?
First of all of these organizations serve low-income families with young children. And over my years in public health, I've worked with many of the organizations and individuals, and I'm familiar with clinical and public health resources for families. But I also sought out guidance from others, and key among those were our funders, who, for example, provided us with access to their grantees. They're very well connected to our community. One funder identified Childhood Feeding Collaborative as one of its top 3 priorities for obesity prevention, and then gave us access to all of their relevant community-based organizations. They hosted trainings for us to reach these organizations. And so really with every other aspect of this work, identifying these was a collaborative process.
That's very interesting. Thank you, Carol.
Yeah. Okay, I want to share with you our accomplishments. To evaluate our interventions, we worked with an evaluation team from Stanford Medical School, UC Berkeley, Atkins Center for Weight and Health, and a private evaluation contractor. Each year, a portion of our grant funds support evaluation. And so I want to share our findings from pediatrician and parent interventions between 2007 and 2011. This is data from our first year in which I piloted the physician intervention with county and community-based pediatricians. The intervention was 2 one-hour trainings held at pediatric grand rounds at the hospital on how to integrate division of responsibility-based feeding assessment and parent education into the well-child visit. Pediatricians were given a pre-test, a post-test, and a 2-month follow-up assessment. We used SurveyMonkey. So looking at the bar graph, at pre-test, only 37% of the respondents were aware of division of responsibility, which is acknowledged as best practice by the American Academy of Pediatrics. After training, 97% were aware. At the 2-month follow-up, we asked a variety of questions related to giving families guidance on issues of feeding and weight. Providers were more confident and felt fewer barriers to taking action and felt that the training provided them with an effective strategy for dealing with issues of weight and feeding compared to a pre-test. In our second year, we took a small random sample of 12 pediatricians who had been trained by me and used an external evaluator to conduct 1-hour-long individual interviews to assess the impact of the training on how they guided parents on feeding. You'll see the results of some of the questions there. And, at the time of this interview, 6 to 12 months post-training, most felt their guidance was consistent with the division of responsibility and also supporting family meal times, which is always emphasized. What we heard consistently from this random sample is that the training on the division of responsibility gives them an effective and consistent way to talk to parents about feeding their child. The division of responsibility gave them the needed vocabulary. There are certainly barriers to working with the pediatric healthcare provider. They are extraordinarily time constrained. There are always other priorities. Just wait till flu season starts and you'll know where their attention is. And they're not trained on some of the more effective styles of dialoguing with parents. Our parent intervention is our 2-hour 5 Keys class. And as I said, it's offered free and also in 3 languages, English, Spanish, and Vietnamese. Our biggest challenge in offering this class is getting registered parents to show up. Providing childcare always improves our show rate, but it's very expensive. So let's look at our parent outcomes at post-test and 2-month follow-up. This graph shows behavior change from our class attendees in 2010. At post-test, we asked parents to identify 2 behaviors they wish to change. And then at 8 weeks follow-up, we have the tender telephone interview and ask them again about those 2 behaviors. At this year, and very similar to every other year, 90% changed 2 or more behaviors. The most common behaviors changed were that parents turned off the TV during mealtime, they served their child the same food as the rest of the family, and they initiated limits regarding when eating was allowed. We asked parents at the end of the class and then at the 2-month follow-up if they have heard division of responsibility feeding messages from any other sources. The increase of awareness that you see between post-test and follow-up, and you'll notice there are 2 years represented here, This increase between post and follow-up may be due to parents becoming more attuned to feeding messages from other sources. In other words, the class amplifies the messaging from others. An interesting finding from asking this question is that we can see the effect of building capacity. In 2010, we added several large public health programs to the collaborative, and so you can see between 2010 and 11, this nearly doubled the percentage of parents who had heard the consistent message at the time of the class. And this is, of course, exactly what we intend to happen. Behavior change is facilitated when adults hear a coordinated message from multiple sources. We ask parents where they've heard the feeding messages. 90% of the sources they identify are childhood feeding collaborative partners. At the follow-up assessment, we asked parents their perceptions of how hard it was to make behavior changes. And there are 4 questions in this category. So looking at the first one, breaking the habit, eating in front of the TV, 3/4 of the parents have no problem or just a small challenge of breaking this important habit. Well, in terms of lack of support from other family members, we all know that family members can aid or abet success with behavior change. Most of our families don't feel that lack of support is a big challenge. These percentages really surprise me, and I bet that they do you too. I also want to draw your attention to the sample size. It has decreased. It's now just 10% of the post-test sample, and it is just really hard to reach our families by telephone. Child's resistance to change, 2/3 of the parents feel it is not a challenge or just a small challenge to deal with the child's resistance to change. These parents were really finding their power, their authority over their children. And breaking the habit of eating throughout the day. This is a crucial behavior that relates to obesity risk. And again, this is just not that hard for parents after they've attended the class. And this is the win of the division of responsibility. We asked parents at the post-test and then at follow-up how many family meals that they eat during the week together. And I'm pleased that the class attendees do value the family meal. We see only a slight shift to the right with the number of meals served per week. And the small sample size makes it impossible to achieve statistical significance.
Carol, it's so wonderful to have this data. I especially like those pie graphs that you just showed, indicating how easily parents make the targeted changes. It's not like that for families who present for clinical intervention who have established or entrenched feeding problems, and I'm wondering if they're the greenies, but of course I have no basis for saying that. But that clinical families have much more difficulty with making the changes. But question for you, I wonder what your subjective impressions are of how families move along with respect to their feeding capabilities.
Well, I don't have longer-term follow-up data. The evaluation team felt that a 2-month follow-up was the appropriate follow-up period for a single 2-hour class. But I do talk with pediatricians and with nutrition staff and other partners on what the parents tell them. And what I hear is parents who say, oh, I wish I had had this class when I had my first child. Pediatricians who will say, parents just get it when I teach the division of responsibility. Parents who will come in and say, I've bought a book, I've referred my child care provider to the class. So a lot of comments like this. So, I hope that's an indicator.
Yeah, I think it is an indicator. That's most encouraging.
And so now I want to go into a generalized discussion of how Childhood Feeding Collaborative grew and solidified the division of responsibility-based feeding guidance. I'll break the work down into a timeline so you can see what it took to get where we are today. And you may find relevance to your own setting within this timeline. In 2002, the Child Health and Disability Prevention Program of the Public Health Department received funds from UC Berkeley Center for Weight and Health to create a Children's Health and Fitness Coalition. And this was at the start of the prevention activity responding to what we now refer to as the child obesity epidemic. The Children's Health and Fitness Coalition brought together people with a common interest, which was reducing child obesity, and it started the engine which led to the Childhood Feeding Collaborative. It was within the working group that I led that a vision for preventing obesity through a focus on best feeding practices was articulated. I actually had to be pushy to get this focus into the forefront. As some of you may have experienced, feeding practices are not what people think of around obesity prevention. It took a passionate and well-informed voice to shift group thinking to feeding practices. Now, this is the vision that the Children's Health and Fitness Coalition group articulated. All families in Santa Clara County receive division of responsibility from all of their relevant service providers. Now, this is big with long-term implications, and it suggests the eventual Childhood Feeding Collaborative strategy, which was cross-systems partnerships and intervention. This was our working vision, but not the one I used 5 years later to sell Childhood Feeding Collaborative, which you have already seen. This is too broad and didn't prioritize obesity, and obesity is where the money is at. So our group from the Children's Health and Fitness Coalition worked together for 4 years to first test the possibilities for a feeding practices-based strategy and then to begin implementing our big vision. Several local funders offered mini grants that required only a letter of intent. These were between $5,000 and $25,000. These small grants offered us a chance to promote division of responsibility and determine if our vision was shared by others. And these mini grants also gave us experience in programming and evaluation. During this period, leadership rotated among our small group, and that allowed us to take advantage of individuals' connections and skills. I contacted Ellen in 2002 to help us begin implementation, and that was a wise move. We needed the experience she could provide. Another wise decision was that we put priority on evaluation, knowing it could create the data set for moving forward. So I want to go into more detail on this startup phase. And the collaboration with Ellen in 2002 was important. She supported our vision and helped us develop a step-by-step plan to gain buy-in and grow community capacity for the division of responsibility. And she did this by very kindly but firmly rerouting our plan of action, and the result was a strategically wise timeline. Public health is run by a hierarchical system. Without the commitment of public health policymakers and administrators, the big goal of Childhood Feeding Collaborative would not happen. At the onset of our activities, we sought out these administrators, educated them, and sold them on the possibility that would become Childhood Feeding Collaborative. And Ellen?
You said that we worked together early on. I remember you asked me to do training, and by then to start out with your group of people, and by then I'd learned my lesson through bitter experience and had found out that trying to start right off with training is too much too soon, and that it raises a lot of resistance. So we started out with a workshop that was called something like the Feeding Relationship, Solving Childhood Feeding Problems, and Introduction to the Possibilities, which was essentially an introduction to behavioral assessment. The thrust of the workshop is to encourage participants to set aside dietary prescriptiveness and to begin thinking in terms of behavior, that is, parent-child interactions around feeding, as the cause of feeding problems and as the route to solving those feeding problems. I introduced participants to the division of responsibility in feeding, gave evidence backing it up, and showed videos of feeding interactions. Then I gave them case examples, often with videos, and invited them to discuss solutions to feeding problems based on the division of responsibility. And so in using this strategy with training, essentially what I do is follow a division of responsibility with training. During this initial step, we say, well, here's the model. What you do with it is up to you. If we started with training, we would be saying, here's the model, use it. Carol?
Yep. Our first activity then was this large conference with Ellen and to introduce the possibilities. And we we're very careful in designing evaluation. And this slide shows you how the evaluation of this first conference provided us with data that supported the need for a childhood feeding collaborative. We were strategic with our invitee list and marketing so we could show the funders that our target group of pediatricians, public health program providers supported our message. They wanted more of it, and they felt they would change their practice as a result of their training. They wanted their peers and parents to hear about it. Now, these are fabulous results. So it was really important to have this initial conference be compelling. Go ahead, Ellen.
Yeah, and of course this data is so phenomenal that it really makes it tempting to skip the introductory step that we just talked about and go straight to training. But for people who are steeped in food selection interventions, shifting to behavioral intervention is a huge change, and even the most enthusiastic people run into resistance. When you let them sit with the material, they work through their own resistance. Here's an example. A key player, a pediatrician, was incensed by the DOR-based child obesity recommendations, and he was convinced that dietary prescription was essential, and after my presentation he tried every which way to get me to agree with him. I stood firm, but I didn't try to persuade him. By the time I saw him a year later, he dealt with his own resistance and had become one of Carol's biggest and very strategic supporters. Carol?
Okay. Next, in 2007, a grant application that I wrote with the help of a talented grant writer was accepted for the funding of Childhood Feeding Collaborative. Now, please don't be deceived by how straightforward I just sounded. There was nothing straightforward about it, and I'm sparing you some of the messy details because I don't think it'll help your learning process. So there are many twists and turns, and many organizations and individuals were vitally important to getting funded. However, the previous year's work had shown that the proposal was achievable, well-targeted, and well-evaluated. I received $110,000 in grant funds, which would support my part-time salary to conduct a pilot with county pediatric clinics, pay for the evaluation, trainings, and educational materials. Our primary partner organization, Choices for Children, received $35,000, and this was a great starting point. The funds, as I said, the work is divided between the two agencies. Public Health Department, the work that I do is focused on leading the collaborative and the work with pediatricians and their referral process to the 5 Keys class. Choices for Children takes responsibility on the creation, piloting, and implementation of the 5 Keys to Raising a Healthy, Happy Eater class. And this created a very logical division of labor among organizations. I sought out expert guidance. We are rich with talent in the San Francisco Bay Area. Pat Crawford, the former director of UC Berkeley Center for Weight and Health, helped me define the evaluation plan, provided input on the proposed project, and then recommended one of her researchers as an evaluation consultant. Pat asks tough questions. She is better connected overall to the national subject area, and she proved to be a very powerful advocate for Childhood Feeding Collaborative. In other words, getting advice from an expert is also a good way to inform that important person. And Ellen Satter was and is important in a number of ways. They've developed parent education materials in English and Spanish. There are the Satter books, and I contracted with Ellen so I could use her as a resource in all areas. We budgeted money for an evaluation team, and this included a statistician. And a stipend is usual for this sort of consultant. Top-notch researchers enjoy small projects like ours. And they gave us a quality evaluation that we have published in the Journal of Childhood Obesity, and that's part of your webinar handouts. The evaluation proved the program's effectiveness, showed us where our weakness was, and the evaluation then became a planning tool.
All right, Carol, you asked me to speak about these. This is the Feeding and Primary Care handout package that I make available through Ellen Satter Associates. Ordinarily, when you buy this package, you get rights to reproduce 300 copies of each of the 55 handouts. Well, since the Childhood Feeding Collaborative was distributing the handouts county-wide, there was no way they could get by with 300 copies, so they bought licensing rights for 14 of the 55 handouts in this reproducible master's series for both the English and the Spanish. And they also took the handouts one step further because they have such a large Vietnamese population. With my permission, they translated these materials into Vietnamese, and I evaluated the back translation to be sure they are consistent with my intentions. Those Vietnamese handouts are available to you at no cost on the ESI website under Programming and Resources, Translated Handouts. Carol?
Let's see. Okay, so after that first year, which really was a year and a half, the focus was on expanding to other key partners that was needed to achieve a county-wide consistent message. And the expansion and scope of work in following years is somewhat driven by by dialogue with our funders. Now, the strategy for expansion was to train feeding experts within organizations, and those child feeding experts could then build capacity for their own organization. In other words, serve as a resource for training and information. It was a train-the-trainer model of sorts, but more strategic. Sustainability was built into the work plan, but sustainability is a myth. Nothing is sustainable without continued input and without staying in the limelight. Ellen?
Yeah, Carol, you contracted with me and with ESI over the years to do quite a lot of training, twice over 5 years. I did the 4-day Feeding with Love and Good Sense Visions workshop, which teaches assessment and treatment of established feeding problems. And Pam Estes, who is an ESI faculty member, also did the 3-day Feeding Dynamics Education and Intervention in Primary Care workshop. I found the participants, and as did Pam, the participants that Carol had recruited to come to the workshop were committed and prepared and ready for the training. As I worked with them, I was impressed more than ever that Carol, you have the gift of connecting with others and bringing them along and helping them to recognize their importance in the broader context. But Carol, how did you get such a good crop of people? How did you identify them for the training?
It was collaborative as always. So I worked with the director or the top administrator from the various organizations, and they would select the appropriate person. They knew their staff better than I did. I then connected with the staff. They had their agency had to sign a letter of commitment for that person to attend, so they would have to develop the person would have to develop a plan of action for implementing division of responsibility training within the organization. They had to really think in advance with this letter of commitment on how they were going to apply the knowledge. It wasn't just a conference they were going to attend and then go back. It was planned and strategic. And so I think it did help to have them do that thinking ahead of time. So I
think you did follow-up meetings, didn't you, Carol? Didn't you do follow-up meetings as well?
Yes, thank you. Yes, we have, at the beginning we had 3 meetings within the first year following training. And now we meet, get our experts together about every other year. And they appreciate that, and it does help. Turnover is a huge problem. We've lost many of them to other jobs. And interestingly, some of them have switched jobs and are still using division of responsibility.
That's great.
Yeah, it really solidified their knowledge, these trainings. So just visually see, these are just a very small set of our partners. Our funders are this on the right-hand side, and also some of these are in-kind providers. But this is just also to remind me to tell you that the best way to sustain and expand a project like this is to mindfully integrate the intervention into these organizations using their existing systems. We always try to use existing systems and not create new systems within organizations. Okay, let's go on to the next area. I want to present Childhood Feeding Collaborative in the framework of the spectrum of prevention. Some of you are already aware of this model. Childhood Feeding Collaborative is transferable to other community settings, and the spectrum of prevention gives a good framework for envisioning the possibilities within your community. What the spectrum does is it helps expand thinking of prevention beyond education models by promoting a multifaceted range of activities. This was originally developed by Larry Cohen, who is now director of the Prevention Institute, and you can go to that hyperlink and get to their website and find the spectrum of prevention within that. This model, conceptual framework, has been used nationally in prevention initiatives targeting traffic safety, violence prevention, injury prevention, nutrition, and fitness. It identifies the multiple levels of intervention and encourages people to move beyond the perception that prevention is just about teaching people healthy behaviors. The 6 levels for strategy development is a framework for a comprehensive plan. It includes policy, organizational systems change, fostering coalitions. These levels are complementary, and when they are used together, they produce a synergy that results in greater effectiveness that would be possible if you just focused on any one of them. Childhood Feeding Collaborative operates at each of the 6 levels, and I actually base my strategic plan on this spectrum. I want to give you a few lessons learned on getting funded, and these are based on my limited experiences within Santa Clara County. The collaborative is funded by local charitable organizations, and there are lots of advantages with using local funders. It gives you flexibility. Child obesity was the favored child of funders in 2007, but at that time, national funders, none of them, were offering grants for early childhood. And so although we were on target in terms of meeting our unmet local need and ahead of our time in addressing early prevention, we needed the flexibility of local funders because we did not meet the criteria of any national funding organization. Local funders can also relate to the community partnerships proposed, and many of those partners were also receiving local funds. Funders like to see their funds connected and synergistic. They also don't like to be the only fish in a pond, and having other funders on board spreads the risk, and their funds are leveraged with others to build a better and bigger project. Relationships are really important when you're working with local funders. My first grantor was hesitant to commit until a highly trusted and well-connected public health department program manager advocated for Childhood Feeding Collaborative. She was respected for her strong management and vision and helped the funder believe that Childhood Feeding Collaborative was well conceived and valuable. I also recommend a relationship with the grants administrator at the organization. That person presents your grant to the grants committee, and it's important to get that person's input and also to make sure they really understand what you're trying to do. And with local funders, you do have the opportunity to educate them, and you will be wise if you accept education from them. You may have to change perceptions from food-based and school-based interventions to parenting. You have lots of good research to support you in that effort. Our funders and community partners had little awareness of the role of feeding practices until we educated them. Let's see, additionally, we could also, by writing into our proposals, an evaluation, we had contracts written that we could show them with these top-notch researchers. That impressed them and certainly built confidence in our proposal. We did develop some educational materials, and these are on my website within the Public Health Department, the Childhood Feeding Collaborative website. You can look at that there. This one is a serving size handout. It's the alternative to portion size handouts that stress how much a child should eat. These are this is based on a good starting point, and the child can eat however much more or less than he wants. On the yellow item, this is a toolkit for anticipatory guidance for the pediatric healthcare provider, and you have all division of responsibility-based feeding guidance. The poster is provides 1 or 2 sentences of feeding guidance for each of the well child visits, and I'm happy to provide soft copies of any of these.
So, Carol, you asked me to talk about this. I told you about the handouts previously, and it is really a source of a great deal of satisfaction for me that you did choose to use them in your program. The video, the Feeding with Love and Good Sense 2 DVD, shows close-up footage of real parents and real children, newborn through preschool, in their homes in actual feeding situations. Some parents do it well, others make mistakes, and it's all instructive. Childhood Feeding Collaborative parents and tell parents what to, CFC members tell parents what to do with feeding, but the videos show them what to do. And of course, the best part of all is I did this, I worked with you in filming this series in Santa Clara County with support in many ways provided by the Santa Clara Public Health Department, and that was a wild ride, wasn't it, Carol?
Yes, to say the least. But yeah, they're fabulous videos. Okay, it's almost time for questions. This is the last slide, and it's closing thoughts. And first is that division of responsibility is logical for a cross-systems countywide intervention. Child feeding practices that are recommended by national policy organizations are filled with good ideas and evidence-based recommendations. But what Santa Clara County has done via the Childhood Feeding Collaborative is recognize that what physicians are looking for, what child care providers, parents, etc. are looking for is a good methodology to underlie all of those good ideas and recommendations. Division of responsibility, the model is the methodology underneath child feeding recommendations. And lastly, I want to acknowledge that the success of the intervention is due in part because we constantly work to stay faithful to the division of responsibility. Fidelity to message is built into every aspect of our work. And without that attention, entropy prevails.
Well, Carol, thanks. That was quite a presentation. All right, everybody, please email us your questions, and we will be answering them in turn. And while you organize your thoughts and send your questions along to us, I'm going to ask Carol the first one, and that is, Carol, what would you say now at this point is your biggest challenge?
Well, sustainability is, and that means keeping division of responsibility in the forefront and integrated and related to all of the other important interventions going on in the county that relate to child health and nutrition. You know, another way to say this is, you know, creating a paradigm shift because that's what makes it sustainable. one thing working in our favor is that the USDA core nutrition messages, and these are the messages that guide all of the food stamp nutrition education programming, have newly made this easier because they base these core nutrition messages on a division of feeding responsibility. They can't use division of responsibility. They can't name that, so it's a division of feeding responsibility, but it's the same thing. And this is, I mean, it's very well thought out what they've done, and it makes it very practical to use feeding practices then as the methodology underlying their other feeding recommendations. And that's all I have to say.
Well, that's great. Okay, Katie, what do you have for us?
I have, as a member of a county-wide partnership that already exists to develop initiatives to prevent obesity and diabetes, etc., where do I start to implement something like this in our county? Do we need to start with Ellen Satter?
Oh, yes, I think you're stuck with Ellen Satter one way or the other. So let me take the first crack at that question, and then I'm going to turn it over to Carol. And I'd say there are two steps to laying the foundation. And, you know, taking a page out of Carol's book, I would suggest that I would highly recommend you take the steps collaboratively, that you figure out your group and you do it as a group. And the first step then is to be well grounded in the feeding dynamics model and the division of responsibility. That's first. And then secondly, be well grounded in the collaborative process. And again, do that part as a group. Invite the principal players that you've identified to participate in a group that reviews this webinar. You couldn't get a better start. And read and discuss all the handouts that we've given you on the website and in the certificate of attendance that you'll be getting. And really get your arms around exactly what this process is all about and what you want to do in your setting. Carol?
No, I think that's exactly right, and I don't have anything to add.
They specifically asked about training with Ellen Satter too.
Yeah, well, after you do your homework and you figure out what you want, then the next stop is the Ellen Satter Institute, and talking to none other than Katie Benzie, who's been facilitating this webinar. And you can go to our website and take a look at what we have posted thus far on training. And the place to start is with the Introduction to the Possibilities workshop that I talked to you about earlier, where we introduce as many people as you can get. Carol, what did we have? 400 people?
Yeah.
It was a lot of people. And this is where we talked about behavioral interventions in addressing feeding and feeding problems. So yes, once you're ready to go and want to start the training process, then it's to the Ellen Satter Institute.
And I want to just add something, is that Ellen she's a big name, and I'm not sure we could have gained the credibility without the authority that she provided. And it costs money, but again, you need to persist and look for these, for some of the small grant funds. And it's surprising where the money can come from, and be creative. And that's why bringing partners in, because they'll find other sources. But I just felt it was critical to have her come in and do that for us.
Carol, you know, I am trying to retire here.
Sorry. Forgot about that.
Well, moving on, we have a couple questions on cultural things. Like, how do you take into account different food cultures and cultures of different nationalities?
Oh wow, you've got a good answer for that with your Vietnamese population, Carol.
So one of our 5 keys, what the division of responsibility does is it helps parents achieve what they want for their child, which is across cultures, parents want their child to eat well, they want them to eat the food they serve, they want them to grow well. And so what the division of responsibility does is give them the parenting strategies to achieve that. And so for most cultures, actually I haven't found one where it doesn't apply, because we're not telling them what to eat, when to eat, where to eat, they set those. That's what they decide. We teach them how to implement that structure with division of responsibility. So we found it not almost culturally neutral, but each culture has different challenges. One of our 5 Keys instructors that works with very low income Spanish-speaking parents, and she has a continued relationship with these. She reported back to me that these parents, mealtime is very important to them, and they would report that mealtime was so much less stressful when they didn't have to be responsible for what the child was eating or how much the child ate. Our Vietnamese parents, they have different challenges, and for them it's letting go of, well, most of the challenges are based on parents letting go of the control over what the child eats. But they're even more entrenched in that, just to make a generalization, but that it is, we've worked with all income levels, and so I would say be sensitive to where the challenges will be and the nuance there.
All right, next question is, can the division of responsibility be integrated in a school setting?
Yeah, Ellen?
Oh yeah, it certainly can. And in fact, I'd encourage you to go to my website, ellensaterassociates.com, and bring up the How to Feed tab, and then you're going to see a lot of really short articles all listed under How to Feed. And if you go to the very bottom of that whole list, you're going to find a bunch of stuff about schools. And so you can, and it's all free and it's all accessible, and so I'd say that's the place to go to start reading about that topic.
I've spoken to conferences held by elementary school districts, and I don't recall if I think some had middle-aged kids as well, and it absolutely resonated. I had loads of questions and people coming up afterwards, so I don't think you have to worry about that, about the resonance anyway.
That's great.
Let's see here. There's one that a couple talks about being a little overwhelmed with all the information, and they were wondering if you had any suggestions to decrease the feeling of how hard it is, how to motivate to start, and how to start.
That's why I wrote that Family Meals Focus about the elephant, and because I felt the same way. And so go back, and if you go to ellensaterassociates.com and go to Family Meals Focus newsletter, is that how it is on that website?
Yeah.
And yes, Family Meals Focus newsletter, and the one for October 12th is about collective impact. And I sort of, I dumbed it down so I could understand it. So I had some fun with it. So I think you'll feel better after you read that.
And and also it's a progression. Start small. And I find division of responsibility an easy. In some ways, it's easy to sell because it is so logical. And anyone that you're talking to who's worked with telling parents what the kid needs to eat and how much, they're frustrated. They're desperate for something effective. And they will see the logic in this model. Pediatricians, some of them won't go near it with a 10-foot pole. That's a very small number. Most of them they use it, they see the logic, and it really resonates. And so the model will help you. And I think, if you're going to sell it, you do need to be passionate about it and really understand it. And so, yeah.
Yeah, and Carol, you commented during your talk that that you had to be really firm and visible and persuasive in order to bring people around to, in the first place, be concerned about feeding as part of the health collaborative, and then in the second place to keep the division of responsibility front and center.
Yeah, yeah, yeah. But just, start small and see, where your timeline goes. It may not look like mine. It may go faster.
Mm-hmm.
Sure, and let's take one more. There are a lot of questions, and they're all great questions. But somebody wanted you to talk a little bit more about the 5 keys.
Oh, the 5 keys. There are 5. The 5 domains of the division of responsibility: the what, when, and the where, and the how much and the whether. Ellen gave us permission to rename those the 5 keys for our 5 keys to raising a healthy, happy eater class. And so it's just the division of responsibility is all of it is. And the 5 keys class is our parenting class that teaches division of responsibility.
Yes, the division of responsibility states that the parent does the what, when, and where of feeding, and the child does the how much and whether of eating.
Wonderful. Well, thank you so much, ladies. I know there's a lot of questions from how to get funding to even things about Santa Clara County, and you will be able to ask those. You can ask more specific questions as well on our bulletin board. And Ellen, Carol, if you could bring that up, and Ellen, if you could tell us a little bit more about the bulletin board.
Okay.
There it is.
Okay, there it is. Okay, you've been given a link to this forum, and if you haven't been given it, it's on the ESI website. The Carol's little hand right now is showing you the directions for how to use this forum, and you have to log in. You have to give your name or some facsimile thereof and your password. And then if you look down where the hand is now, the major heading is Collective Impact, Multidisciplinary, Collaborative Practice, and then Carol will click on Countywide Intervention with Child Obesity, which is today's webinar. Oh, and for some reason it just dumped her out of that, but
that's how you log in.
That's how you log in.
There you go.
But we set up one of these topics for every one of our, well, there it is again. We set up these topics for every one of our webinars, and you'll be able to read back about other webinars, as well as have a broader discussion with Carol, with me, with the other Ellen Satter Institute faculty members, and with each other on this forum. So a very good resource, I think you'll find. Before I sign out off, I'm going to beg you to please fill out your evaluation, the evaluation that Katie talked about earlier. You're going to get a link to it in an email. It's quick and dirty, and it just makes it so good for us to hear from you and to get your feedback and advice about this ongoing webinar series. And so that's all I have to say. Katie, Carol, we'll say goodbye, and then over to you.
Yeah, thank you, Ellen, and thank you, Carol. And again, thank you, everybody, for spending the last hour with us. We appreciate your support. Again, an email will be coming out following up that gives you the handouts, a certificate of completion, and a link to the evaluation, and of course the billboard that we just discussed. A lot of people have asked specifically, where to start, where to get all the information we talked to, and go to ellensatterinstitute.org. It's all on there. It's pretty clean site. It's pretty straightforward. And if you have any further questions, please go to the billboard site, because the bulletin board site, because that's you can talk to us anytime. So thank you again, and thanks for your support. Everyone, have a great day.